care of the woman who presents with PPROM from 24 weeks of gestation. So the summary of this guideline includes that how first you will diagnose. One point should be the clinical diagnosis, the history of the woman which she's when she says that she's having leaking, right? So woman giving history of leaking, number 1 point, and after that you do the perspeculum examination and you see the amniotic fluid inside the vagina. If you don't find any amniotic fluid, you can take the vaginal fluid for the insulin like growth factor protein, binding protein number 1, and PAMG1 testing, that is placental alpha microglobulin protein testing. And after that, how do you manage? Once you diagnose, how do you manage? So you have to first see the other clinical symptoms of the patient, in the sense fever, pain, foul smelling discharge, this and the fetal heart rate of the baby. If they all are within normal range or normal limits, then you can go for expectant management till 37 weeks in a woman who is asymptomatic and having PPROM diagnosis made already after 24 weeks of pregnancy. You can offer her corticosteroids, you can offer her Maxilf if she goes in labor, right? If she goes in active labor, only then Maxilf is to be given, or you expect the delivery is within 24 hours from now. Then you can offer her Maxilf, and as soon as the diagnosis of PPROM is made, you offer the patient tablet erythromycin as the antibiotic of choice for 10 days, and the dose here will be 250 milligrams 4 times in a day. So dose is for 10 days or till delivery, whichever is earlier, right? And meanwhile, during the expectant management, what are you supposed to do? The woman is supposed to assess for the clinical symptoms like fever, pain, discharge, fetal heart rate. If she is in-house or in hospital, then the pulse, blood pressure, respiratory rate and temperature are to be monitored on obstetric early warning score and score chart. And also the routine clinical investigations, that is C-reactive protein and WBC. In an asymptomatic woman, this can be done once or twice a week, okay? And that is how we watch them for any further deterioration. So, and there are like the patient should be spoken or met with the neonatologist for the care of the baby or to know the outcomes of the baby if deliver early, right? And there is no evidence of amnio infusion, though it prevents the cord prolapse or cord compression. It also prevents the deformities, physical deformities due to the less amniotic fluid and the pulmonary hypoplasia. But as the studies like Cochrane review does not found it significant, so they says that there is no evidence that amnio infusion should be prescribed to the women with PPROM on a regular basis.